So you know that the brain is wired crossways, so the left brain controls the right body. Okay. I know you have some symptoms in your left leg as well, and your spine MRIs are not perfect, but they're pretty good for your age, and you do have some arthritis in your spine, and you are overweight, and it's not unusual to have some pinched nerve or something in the leg.
Right.
There's nothing in the spine that requires surgery as far as we can tell from the images. Okay. This is a scan of your brain, and we have one from November and one from now, so 6 months apart. And the radiologists are not 100% sure, but they think there may be a slight increase in the size of this cyst. And the cyst is the fluid area here. Fluid is white in this section. And the brain, nature likes symmetry, okay? So normally we hope that everybody has eyes the same size, ears are the same height on the head, equal number of fingers on the hands, etc. So if we look at the top of the head, you see that there are these Mickey Mouse ears that are called the ventricles filled with fluid, left and right. And this side of the screen is the left side of the body. And you see that here, a kind of trefoil appears, and as we go down, it expands and it has some kind of membrane in it. You see that?
Yes.
Okay. So there's this cyst there. And if we look at it in another view, now fluid is black in this view, in terms of where it is on your head. That's the eyeball, and that's the size of the eyeball. And there is the cyst, so larger than an eyeball. Okay. And it has its own, it appears to have its own wall, separate from this fluid here. The brain fluid here is produced and absorbed constantly. It's called cerebrospinal fluid. If this is entrapped somehow, then maybe it's not being produced and absorbed. The brain around here, above it, controls movement in the opposite side of the body. So this is the left side of the brain. Therefore, the right side of the body might be more clumsy, less steady, easier to fatigue, etc. This is most likely, the diagnosis is a porencephalic cyst. And a porencephalic cyst is an error in infolding of the brain during the embryonic stage. Meaning,
So it wasn't birth trauma.
well, I don't think it was birth trauma. I think this was something that happened by maybe 28 days of gestation as a fetus, but occasionally they can happen. They have been documented to happen with trauma as well. Regardless whether it was in utero or birth trauma, it would have been with you many decades, and we're not sure why it's symptomatic now. Now, the radiologists think that maybe it increased in size over 6 months, but 6 months is a fairly short period. And
Considering I had it that long.
yeah, and when we take these cuts on the MRI, one MRI might take the cuts like this, and the next time you tilt your head in the scanner, the cuts might be like that. And so, depending on this angle, if it's not exactly the same, the size could appear subtly different. Does that make sense?
Yes.
And so, I am not certain that we need to jump on treating it, but I can tell you that the way to treat it is to put a shunt in that drains fluid out. Essentially, we stick a little catheter in it, a tube, and we put that under the skin and we drain it out to the belly somewhere, or we go through the front here and we open it to communicate with the rest of the ventricles. But when we just make an opening, it can scar back up maybe and close back up. So, sometimes a shunt is better. but it is not something that is mandatory. It doesn't have to be done unless we think it's growing, we're changing, doing something. 6 months with questionable increase in size doesn't tell me we should do something, because if we place a shunt, it's a permanent implant.
Or you
Mm-hmm.
can't take it out?
Well, you can take it out, but then it doesn't work once you take it out.
So you can't just drain the cyst and hope that it just stays?
Drain,
Or
no.
even remove it?
Well, you can't remove it because the wall of it is embedded in the brain here, see? So if we drain it and it reaccumulates, it's near this ventricle that has normal brain fluid. So if the fluid gets repeatedly entrapped and accumulates there, it's not gonna work. And so we usually, when we shunt it, it means we put a catheter in it and we thread that under the skin all the way. We drain it to the peritoneum, the area between the organs. It's not a big deal, it's not a big surgery, but it is an implant that you have now for the rest of your life. And so we don't want to do it unless we are convinced it has to be done. Okay. Okay, here is another view of it. And you see how there is a membrane here to this fluid area and another one there. So I think it's definitely an entrapped cyst. We can go in there, if you don't want to shunt, we can go in there with an endoscope with a camera and open up that membrane and try to get it all to drain. I'm just not sure if that's permanent. It could gum up again.
So
the membranes could.
isn't there, like, for lack of a better term, a stent or something you can put?
There's not really a good way to anchor it to anything in here. We do some shunts like that, the little stents in the spine. But generally here we would just resect that membrane and then that membrane and try to just keep them open. And I'm not unwilling to do that. The question is, how big of a bother is it to you now? How much does it impair your function? Is it worth the risk of an open brain surgery or not? That's the question.
Well, I mean, it's impairing my ability to ambulate without assistance.
How long have you been using a walker now?
Just since this thing happened.
Okay.
Because
So
I'd be okay with just a cane probably, and I don't even use the cane. I should.
you're having surgery on that soon?
Tomorrow.
Okay. How long is the PT and recovery after that?
They didn't talk about PT, but I'm guessing because so many people have had the surgery, so I've had friends telling me, that it's a short recovery. And unless he does the burr holes in the bone to build cartilage, then it's a 6-week recovery.
Okay. How long do you feel you've been impaired for?
It became super obvious when we went on a cruise in November, and with all the children, their spouses or families. And I tried to go to the Mayan ruins with them, and I couldn't keep my shoe on. My shoe kept coming off, my foot would go in one direction, the shoe would go in the other. And I was like, I don't know what's going on. But prior to that, I was very sedentary because I was working night shift at home and just would be a couch potato basically, the truth be known. Just not getting enough rest.
What were you working at night?
I'm a nurse and I work after hours for People's Health.
I see.
But they were bought out by United Healthcare and so laid off our entire department. So when they announced the layoff, I couldn't have danced any faster. I was so excited because I needed to get rid of that stupid job. It was killing me. fluid, which is fine for now.
Dr. Koch, I have a question.
Uh-huh.
If it has taken a long time for that cyst to accumulate that fluid, if putting a shunt in to drain it and then removing the shunt, wouldn't it take that amount of time for it to accumulate again?
Well, this fluid cavity here and the cyst here, we're not sure if they communicate with each other or not. If brain fluid gets trapped in there, in which case it would accumulate rapidly, or if it's just the fluid got trapped at birth and it just happens to expand now. We're not sure of that. But there are two thoughts in kind of treating it. One is go in and take out the membranes and make it communicate with the rest of the ventricles, because that fluid is constantly produced and absorbed. That surgery involves putting a camera or a little tube in the cyst where it comes closest to the surface to see inside and to cut those membranes. It's a little more invasive, but it might be a one-time fix. Okay. The second option is to not physically open it and look at it, just to put a catheter in it and drain it out. And then we don't know how quickly it would accumulate. We don't see the membranes, we just kind of put it in under a computer guidance and we put it under the skin. The advantage of the shunt is that the track it makes in the brain is very tiny. It's about the size of a pencil lead, so less likely of disrupting normal brain fibers, but it is a permanent implant. The other procedure, which is called the fenestration, opening a window in the cyst, requires us putting a little cannula, a little tube, so we can see inside. Whether we stick a camera in or we put our microscope, we can see inside. If you didn't want a permanent shunt, fenestrating it would probably be a reasonable option. And if we fenestrate it and it then tries to reaccumulate, then we could shunt it. But fenestrating it means we have to choose a place to open the brain somewhere to look inside it. And you see how it comes close to, these are folds in the brain, and the wall of the cyst comes close to some of these folds. And so we have to choose a place where it's very close to the surface, but also a place where this cortex is not responsible for movement of the arm or leg. So when we open the head, we stimulate with little probes, and we watch your fingers and your legs. We have little needles in, and we have to choose the place that is the safest.
And she's alert during this?
No, she's asleep.
Okay.
She's asleep.
Well, I mean, I know there've been.
Yeah.
I know, I didn't even think of that.
We do awake surgery if we're trying to test speech, because there's no way to see if that works or not unless you're awake. But with this type of stuff, we just have little needles in your muscles, and we can stimulate and check. But if you feel you're sufficiently symptomatic that it's impairing your quality of life, then we probably can treat it surgically.
So I guess you're saying that the cyst is probably the cause of this.
Well, let's put it this way. This is the brain here that's responsible for moving the right side of your body. This is the brain that's responsible for moving the left side of your body. This looks normal and your left side works pretty well, and this is abnormal, so it kind of makes sense.
So it's part of the brain that involves movement.
This is here. Here. It's underneath that area.
Okay.
And that is known as the primary motor cortex.
Okay.
So that's responsible for movement. Now, the brain just in front of it is responsible for planning of movement. Just over it is movement, and just behind it is sensory feedback from the body. Now, it is possible that it's been like this for many years. You could take, maybe if we had a scan from 20 years ago, what if it looked the same size? You say, well, I was walking fine then, why is it not working now? And the fact is, the brain, the neurons have a certain degree of plasticity, meaning they can reshape and work around being stretched. But when they're stretched and malformed, they are going to age or decline in their function faster. You see what I mean? And so even if the size of it was relatively constant, it means that the neurons had a lower functional reserve, meaning they worked well for a while and they stopped.
Okay, another question. Is the fluid in the cyst the same as cerebrospinal fluid, or is it a cystic fluid all of its own?
It's probably very similar, but it looks like it's not circulating, like it's trapped separately.
Right.
So the exact salts in it are going to be different than in spinal fluid, but it's not a gel or it's not something else. And it's not going to be a malignancy. It's not a tumor. The wall of it is not enhancing. I don't expect any kind of tumor associated with it.
So if we opened up the channel into the ventricle,
Mm-hmm.
would it not backfire because it's constant fluid in the ventricle? It wouldn't force fluid back into that.
The cyst then would have the same fluid as the ventricle,
Right.
but in the ventricles, the fluid is under relatively low pressure. It's constantly made and constantly drained, constantly made and constantly drained. So the body's natural pressure in the ventricles is not so high. You know, this one isn't pushing into the brain that way. You see what I mean?
Mm-hmm.
But it could be that
So
we
it
open
does
this,
job.
we open this up, and the shape of it might not change very much because the brain architecture has been shaped around it for decades. I might do a good surgery and we'll take an MRI and we'll say, oh look, the cyst is the same size. But the fluid pressure inside it is going to be lower.
So then that would reduce the symptoms?
Maybe, or it would stop you from getting worse.
So that cyst is not going to shrink no matter what we do?
I'm not saying that. It may shrink some, okay? But this brain, which is missing, okay, these are developmental. We're told they happen around the time of birth, okay? This brain is missing here, okay? It has reshaped, remolded for decades. Do you think it's going to grow back because I take the cyst out? No. It's not a lizard's tail. It's too complicated of a tissue. It's not going to grow back. Okay? So even if the pressure in the cyst decreases, okay, it will never look normal.
But it could improve slightly, the
Yes.
symptoms.
This is what we hope. That the symptoms would be better, the cyst would be smaller in size, and under lower pressure. Does that make sense?
Mm-hmm.
It's like it's a bag of trapped fluid. Reduce the pressure in it, brain has more room around it, relaxes around it a little bit, maybe your function is better. Or we stop your function from getting worse.
So it sounds like the best case scenario is to do the shunt rather than risk.
The shunt has less risk at the time of surgery, but it can get occluded or infected, and you have it with you, and we need to manage it. You need to see me more often. If we put a programmable one, a magnet can adjust it. Whenever you have an MRI, you need to reset it. So it's not without, you know, its own issues, but it's just a tiny thin catheter. You know, now the camera that we put in there is a little bit larger. It's like your pinky finger, and we put it through one of these deep wrinkles in the brain, but we have to disrupt somewhere a little bit of fibers to get to it. And we can, you know, we promise you that we test everything and we go through the area that is least likely to leave you with weakness or numbness. The risk is not zero, but it's low. So those are your choices. Now, in terms of, is it a technically difficult surgery? No. Is it long? No. It'll be 30 minutes, is it, are we fighting some kind of difficult tumor or aneurysm or something? No. It's just a bag of fluid. But it's in an important area of the brain, in the hemisphere that controls the right side of the body.
How many of these surgeries have you done?
I have drained countless collections of fluid from the brain, but they're for different purposes. Poor encephalic cysts are extremely rare, in the order of 1 to 1 million, and so very rare. So I see maybe 1 a year. Some of them don't need to be treated at all, but we do a lot of shunts and we make a lot of holes in the head, a couple of times a week.
And usually without.
Depends on the location.
or-
Depends on the location, right? If it's here in the front, okay, we can cut off half the lobe. We used to do lobectomies for depressed housewives, right? And they were fine, right? So it depends where it is. If you cut out some of the motor cortex, then it's not good. And so, yeah, but I would say the risk profile is low, but all the brain back here has some function. Vision, sensation, movement. And so when we disrupt any fibers, we can't be sure that you won't wake up and say, my pinky is numb, or I feel like my peripheral field is blurry, or, we have to choose a place to go through, whichever way. The question is, if we do nothing, is that a lower risk? If we do nothing. Anyway, if we do nothing, okay, it's not threatening your life, it's not a cancer, it's not going to grow and kill you, but if it is causing sufficient functional deficit over months or years, you're a nurse, you should know if your current quality of life is acceptable or not.
So both paths have consequences of their own.
That's right.
I got this meniscus tear from misusing the leg, due to the weakness in this leg.
I see.
I've stubbed my toes, the middle toes, frequently because they'll drag. Sometimes I can walk normal, and then sometimes I don't walk normal. So I have to be constantly alert, making sure I'm picking my foot up, and working, to make sure I'm walking as normal as possible. If I just
Are you having any symptoms at all in the hand, in the arm?
the fingers, I can't hold things for very long, too many things, or something too heavy.
Were
Eventually
you
it falls
originally
out.
right-handed?
No, I've always been left-handed.
You've always been left-handed. Okay. So, why don't you try to get over this operation, do your recovery so that you're fully recovered from this, and then at 6 weeks, give us a call and let us know if you would like to book an intervention for this. And the choices would be, fenestration or shunting. And I'm fine with either. I think fenestration might be less trouble long term, because sort of you do it and it's done. And there's nothing to manage.
Keep it open.
But you can't put anything to keep it open. I would just have to physically really see there's a thin membrane there.
Right.
I have to cut it from there to there and make sure that it stays open. And there'll be another one down here.
Right.
We have to cut that one and make sure it stays open. And generally they will. I just can't
Right.
swear that it will. So
Well, then that might be the best way, and just cross my fingers and hope.
that it stays open.
Right.
It's big enough, the cyst is big enough that
Right.
we'll have a ample space to work in and look around and keep it open.
Okay, I think that's the best way.
And you can book it at a time when it's convenient for you. We'd expect that you would be in the hospital overnight. And when we drain all this brain fluid, sometimes you feel woozy, your pressure in the head is different, but over a day or two it builds back up. So most people will spend 1 or 2 nights in the hospital. And then having that hospitalization for a brain issue may get you authorized time in rehab if you wanted to go and work on
Absolutely.
that side of your body in a nice rehab facility for 10 to 14 days. Right now, even though you're weak, we can't get that authorized. We can't send you to inpatient rehab, but you know.
And that's exactly how I felt like I needed, but I don't know how the hell I'm gonna get in there. I need rehab.
So insurance companies are tricky about it, but the way to get in is as an inpatient, you know, to go in.
So, doing the fenestration, what's the recovery?
As soon as the skin is healed, you go back to doing whatever you can.
Okay.
The bigger question is, what's the recovery in your right hemi-body function? It's hard to predict. It's all variable. How long it's been dysfunctional, how long you've had it there. We only know the story from November,
Right, but I think it's been there longer.
for sure.
My son, complained that I was wobbling back when I was visiting him in Italy, what do you think, 3 years ago?
Mhm.
Yeah.
He said, Mom,
Yeah, that's right.
you're not walking right.
Yeah,
you're
you've been, and since the sixties, Don, she's always walked to the left. You know how to jump
walking.
Drifting a little bit.
outside,
Yeah.
when you're walking down the sidewalk, and she would always be crossing into me and
Uh-huh.
going left,
Yeah.
and that's since '66.
Yeah.
And the trouble as far as walking and whatnot, that's been going on for several years.
Yeah. So, so I am uncertain how much recovery you're gonna get. Is it 10%? Is it 80%? But if you're getting worse, maybe reducing the size of this thing can stop you getting worse, arrest the progression of things.
Right.
That's where we are.
Okay.
But there's no time pressure. I mean, you've had it for a while. It's not an emergency. Press silent on that answer.
My daughter's getting married November 1st,
Uh-huh.
so I don't wanna do anything to interrupt or,
Okay.
get in the way of that, event.
So, do you want to do it this year though?
I would like to.
Okay.
I think the sooner the better, but
Why don't you come in, pick a date, a tentative date with the staff sometime in November, and right before that date have a new synaptive MRI, which is one of the MRIs we use to navigate things in surgery. Is this a synaptive MRI? You know?
I don't know. I don't remember that word being used.
Doesn't look like it is. Okay. Why don't you get a synaptive MRI now for surgical planning?
Okay.
And then we'll repeat it in November. It's a more precise MRI that maps out all the brain fibers around it. And so we can get one now, then repeat one in November, see if the shape has changed at all. And then we're going to tentatively plan on that fenestration in November. Okay, and you have to get well from your knee and just be safe until then to not have a fall or a spine fracture or head injury or some other thing related to this while you're putting it off.
Exactly. Yeah, I'm really trying hard not to fall. I'm terrified of falling because, too old to fall now.
Do you have a pen?
No, baby, we're here. We're just waiting.
Okay.
Hang on.
So here's my card. On the back of it, I wrote the name of the cyst and the current dimensions.